I've emailed my slides, so you're welcome to share that. And please feel free to jump in and ask any questions at any point in time. It does make it far more fun than having a silent audience.
Yeah, thank you.
And I think you can hopefully see the slides.
Yeah.
Yep. And is that just of one slide, or has it got the second slide on there as well?
One slide there. The second slide also we can see what is going to come next.
Oh, okay. Now how do I change that? I don't know. Doesn't matter. Okay, well, look, I guess today I'm just going to talk to you about commonly used medications in chronic kidney disease, dialysis, and transplantations. And I've got nothing to disclose. And so what I thought I'd talk to you today is just the basics of renal function, which you'll already know, and then talk to you about medications in chronic kidney disease, dialysis, and in transplantation. And I kind of think of the kidneys as having 5 key functions. So the majority of us are born with 2 kidneys, with a single artery, a single vein, and ureters which leave. About 1 in 200 people are born with congenital abnormalities of the urinary tract, which leads to structural abnormalities. You know, so that we do see that. Some people are born with 1 kidney, some people are born with a horseshoe kidney. And of course, you can have multiple arteries, multiple veins, and multiple ureters. And within the kidney, we've got the key filtering unit, which is the nephron. So we have an afferent blood supply, blood going in, and then that breaks into the glomerulus, multiple blood vessels, and an efferent arteriole, which leads blood away. And then we've got Bowman's capsule, and we get filtration and the protourine being formed. And that protourine is modified as it travels through the tubule, the loop of Henle, the distal tubule, and the collecting duct. And so the nephron and the kidney are key for the key functions, which is number 1, eliminating toxins and waste products, the standard things that are formed as a byproduct of metabolism. The kidney has a key role in terms of control of the blood pressure and also regulation of minerals, sodium, potassium, calcium, phosphate, magnesium. It also regulates fluid balance, i.e. if you drink 5 liters, it'll pass 4.5 liters of that. Or alternatively, if you're a Kalahari bushman and you're not got much water, it will concentrate the urine. So it's key in regulation of fluid balance, and also regulation of acid-base balance, and also linked to the lungs. And it also produces hormones that act in a paracrine fashion, so act locally within the kidney, such as renin and aldosterone, but also hormones that act more systemically, such as erythropoietin. So those are kind of the key roles. So we define renal impairment in chronic kidney disease as an abnormality of kidney function or structure, which is present for more than 3 months, which has implications for health. Okay, so that's a slightly modified description, and modified in the sense that you know, it involves implications for health, right? So some of the markers of kidney damage can be a structural abnormality. And so we think of conditions such as polycystic kidney disease. So an autosomal dominant condition where there are cysts that are developing. And in the early stages, you just get cysts forming without a change in blood pressure, without proteinuria, without albuminuria occurring. And this might be diagnosed in childhood. It's an autosomal dominant condition. So if you have it, you've got a 50% risk of your children having it. So it might be diagnosed very early, and it may not be a problem today, tomorrow, next week, but people might run into problems when they're in their 50s. So that's where you can get a structural abnormality. If you have a history of kidney transplantation, if you have an abnormal urinary sediment with the presence of hematuria, blood, or proteinuria, and that proteinuria or albuminuria defined as a urine albumin creatinine ratio of more than 30, a histological abnormality, or if you have a tubular abnormality where you might get an abnormality of the minerals, or a decreased GFR of 60 mils per minute. So we define all of those as markers of kidney damage, which has been present for more than 3 months. So the key role of the kidney in my kind of head, or the major problem we see, is where there's a problem with an elimination of the waste products, typified by an increase in the creatinine, which is mimicked by a decline in the glomerular filtration rate. And so the glomerular filtration rate is the rate at which blood is cleared of waste products. And typically the blood is cleaned by the kidneys at a rate of about 120 mils per minute of blood or more. And so one of the waste products that we typically measure is the creatinine. And so the creatinine is a waste product produced by muscle metabolism. And so if your creatinine is elevated, this is likely to represent a decline in how well the kidney is working, or potentially it might reflect increased muscle mass. And so we can stage chronic kidney disease based on the severity of the decline in the glomerular filtration rate. And we typically say, look, there are 5 stages of decline in the glomerular filtration rate, CKD 1 through to 5, which 5 being the worst, where there's a glomerular filtration rate of less than 15 mils per minute. And similarly, the kidney can leak albumin or protein. And we've got 3 stages of albuminuria. So CKD A1, where the urine albumin creatinine ratio is less than 3, CKD A2, where it's between 3 and 30, and CKD A3, where it's more than 30 milligrams per milliliter. But when we interpret that, it's important just to note that your glomerular filtration rate will get worse with age. So for instance, if your GFR is 40 mils per minute and you're aged 85, I would postulate that it's far more likely that there's something else that's going to kill you than your kidney failure, right? So, that statement that this has implications for your health is really important. So in general, we wouldn't see people who have minor degrees of renal impairment who are elderly. But if you're 20 and you've got a GFR of 40 mils per minute, we would be very likely to see you, and we'd be seeing you pretty quickly. And so the prognosis in terms of your kidney function is really linked to the degree of renal impairment based on either the glomerular filtration rate or the amount of albuminuria that you have. And this graph is really suggesting that if you have normal glomerular filtration rate more than 90 and you're leaking a minimal amount of albumin, then your prognosis is very good. If you've got normal renal function and you've got heavy proteinuria, you've got a moderate risk of progressing to end-stage kidney failure. If you've got moderate renal impairment and no albuminuria, you've equally got an impaired risk of progressing to end-stage renal failure. And when you got both of them, it's double jeopardy. The effects of those 2 things are cumulative and carry an increased risk more than the sum of the whole. So we can define your risk of progression based on the severity of renal impairment and the degree of albuminuria. But that also extends to other things. And so what I mean by that is if you have reduced renal function with a reduction in glomerular filtration rate or albuminuria, you're more likely to die of all causes and more likely to develop a cardiovascular event, and actually also increased risk of hospitalization and prolonged stay in hospital. So as well as being bad for your kidneys, it's a general marker of badness. So any questions? No, so as we move through those stages of chronic kidney disease, we start to see different complications occurring. And if your glomerular filtration rate is more than 90 mils per minute, you've only got a mild loss of function, and you tend not to have too much in the way of symptoms or signs. In stage 2 chronic kidney disease, we start to see much worsening high blood pressure. In stage 3 chronic kidney disease, we get hypertension, anemia, a fall in the blood count, and early changes in the impact of chronic kidney disease on bones. Stage 4, people often start to develop symptoms. So they start to develop the early symptoms of these waste products building up of uremia. And people will start to develop symptoms where they lose their appetite, where they're feeling tired, where their skin starts to become dry, and they become nauseated and anorexic. And that, of course, progresses to stage 5 chronic kidney disease, where you feel tired all the time, you can't do what you want to do, you feel anorexic, you're nauseated, your skin feels extremely dry and itchy, and you feel extremely poorly. So one of the early things that we see in early chronic kidney disease is the development of hypertension. And the worse your blood pressure, the more that it accelerates decline in your kidney function. And the flip side is if we intervene by lowering blood pressure, we can slow the deterioration in kidney function. And that's been known for 20 or 30 years. The worse your blood pressure, the poorer your kidney survival. And so we try and improve blood pressure to improve kidney survival and also reduce the risk of heart attacks and strokes with a combination of lifestyle and medications. So typical medications that we'll use, typical lifestyle changes that we'll include loss of weight if you're above a healthy BMI, restricting salt in the diet, moderate exercise, stopping smoking, and cutting down on alcohol. And in the absence of renal disease, those lifestyle changes can be extremely effective. And in the early stages of chronic kidney disease, those lifestyle changes can be effective at normalizing blood pressure and slowing the progression of chronic kidney disease. But often as kidney function as kidney function declines and you move through the stages of chronic kidney disease, you need drugs to be added to lifestyle changes. Lifestyle changes by themselves aren't effective. And so we need to add medications. And often we need to add several medications to achieve blood pressure targets. And these are a summary of a number of trials that have been done. The modification of diet and renal disease, ABCD trial, hypertension and therapeutics, UK-PDS study, which achieved different blood pressure targets. And what we saw was that actually you need multiple drugs in addition to these lifestyle changes to try and achieve good blood pressure, to reduce risk. So when we think about blood pressure treatment, we want to focus on lifestyle and 3 key areas of therapeutics. And those key areas of therapeutics include natriuresis, so trying to get rid of salt. 2, targeting the renin-angiotensin system. And 3, targeting the sympathetic nervous system. And we think sodium is super important. So we use diuretics, but we're not using diuretics so much for removal of fluid. We're typically using it for removal of salt, for that natriuretic effect. Because salt is kind of the final common pathway in terms of driving blood pressure. And for many people, if you can cut your sodium intake down, then blood pressure improves, but also the number of medications that you need to achieve good blood pressure comes down as well. So, the average New Zealand diet has about 140, 150 millimoles of sodium a day. And if you can reduce that diet to less than 100, then often the number of medications you need can come down. So a low salt diet is really vital, as well as therapies targeting removal of salt. So again, when I think of blood pressure medications, there are a whole lot of classes. There are alpha blockers such as doxazosin, which dilate blood vessels and have side effects of dizziness, but are very effective for people who have prostatism. Alpha agonists such as clonidine have side effects of dry mouth, but they're safe in pregnancy. ACE inhibitors and angiotensin receptor blockers, and actually mineralo receptor antagonists such as spironolactone or plerixafor, they target the renin-angiotensin system. And these drugs are very good in diabetes and have specific benefits in patients with chronic kidney disease, but they are associated with the worsening of potassium, which we all know can be a problem. Beta blockers slow the heart, but then can be associated with fatigue and erectile dysfunction. But if a patient has ischemic heart disease or heart failure or atrial fibrillation where you're trying to achieve rate control, they can be very effective drugs. Calcium channel blockers dilate the blood vessels, can be associated with edema, and good in conditions such as Raynaud's disease. And of course, we're keen on diuretics to try and induce natriuresis. So we can have long-acting diuretics such as chlorthalidone, or shorter-acting diuretics such as furosemide or bumetanide. And then we've got the vasodilators such as minoxidil, which we often think of fourth or fifth line types of therapies. So if we have a young patient or a patient with chronic kidney disease, we'd often use the ACE inhibitors or the angiotensin receptor blockers, because often these patients have an excess of renin-angiotensin. In patients who are older, we might start therapy with diuretics and then think about calcium channel blockers. So the first step is to start one of those drugs, try and optimize the dose, and then consider adding a second drug. And most patients will need at least 2 drugs, if not 3 drugs, to try and achieve really good blood pressure control. We are extremely keen on agents that block the renin-angiotensin system. So you remember that the ACE inhibitors and the angiotensin II receptor antagonists are targeted to these drugs, to these enzymes, which are mostly produced in the kidney. The ACE inhibitors do have adverse drug reactions, and so they can cause cough, or they can cause angioedema. And the funny thing that I think about angioedema is that sometimes you can see these patients who have been on ACE inhibitors for months, if not years, and then later on they develop tongue swelling or lip swelling, and it might occur just once or twice, but then the severity tends to increase. So if you do have a patient who's getting angioedema and they're on ACE inhibitors, even if they've been on it for a very long time, it's really important to have that high on your list of differentials. You can get dysgeusia, where you get taste change, and patients can obviously be at risk of postural hypotension. We don't prescribe it in pregnancy. It can cause birth defects, specifically affecting kidney structure in the fetuses. And in patients who have renal artery stenosis, it can cause sudden and severe dips in renal function. It can also cause a low white blood cell count and an increase in derangement in liver enzymes. So that's really our focus in terms of blood pressure. Another extremely important target that we focus on in terms of therapeutics in chronic kidney disease is proteinuria. And I mentioned that high blood pressure is a risk and an independent risk of progression. And if we intervene, then we can improve outcomes. The same is true with proteinuria. So this very old slide shows that if you have heavy proteinuria, more than 3 grams a day, your kidney prognosis is much worse than if you have moderate proteinuria, and much worse than if you have mild proteinuria. And similarly, if we can intervene and reduce proteinuria, then we can improve kidney outcomes and progression of chronic kidney disease. And once again, we focus on a combination of lifestyle as well as drug therapies to try and reduce proteinuria and improve progression of chronic kidney disease. And the first is, again, weight loss, trying to reduce weight to a healthy BMI. The second thing is protein restriction. So in patients who have moderate protein leak, you might think, well, look, shouldn't we give these patients more protein to try and normalize their protein level? Well, actually, the leakage of protein is both a bad prognostic sign, but it also directly causes damage to the kidney and increases the degree of fibrosis. So it's been found that if you moderately protein restrict the patient with dietary changes, typically to 1 to 1.2 grams per kilogram per day, then you can actually slow progression of chronic kidney disease using that moderate protein restriction. And one of the reasons we're so keen on the ACEs and ARBs is that they have an effect on blood pressure, but also reduce proteinuria. So these drugs are very good for patients with proteinuria. And for instance, in proteinuric conditions such as minimal change disease or FSGS or membranous nephropathy, where you might have preserved renal function and normal blood pressure, but heavy proteinuria, we'll typically start these ACE inhibitors and ARBs and aldosterone antagonists, such as spironolactone, because we're trying to reduce proteinuria, not treat the blood pressure. Finally, statins can be really helpful. So you remember we use statins, HMG-CoAs reductase inhibitors for patients to lower lipids and improve cardiac outcomes. But actually the statins have an effect on the Rho GTPases and help to reduce fibrosis. So again, in patients who are proteinuria, these drugs can be very effective at preserve or have some effect at improving and stabilizing kidney function. And then we'll, of course, try and treat blood pressure. Lowering blood pressure can also help optimize progression of chronic kidney disease in proteinuric patients. So first line is usually ACEs, ARBs, or aldosterone antagonists, something to block the renin-angiotensin system. And if you've optimized the dose, then you'll add a second line drug to try and reduce the blood pressure. So key message number one, proteinuria and hypertension control are extremely important in patients with chronic kidney disease. With proteinuria, the drugs that we focus on are ACEs or ARBs. And in hypertension, we'll use different classes of blood pressure medications, typically using multiple classes to achieve blood pressure control. Okay. So any questions on that sort of initial component? Okay, so I'm afraid you guys cannot continue to remain silent. I've got a question for you. What is the most common cause of end-stage kidney disease?
Diabetic mellitus, hypertensive.
Number one, diabetes.
Sorry?
So number one, diabetes. Who agrees?
Yes, diabetes.
Excellent. You guys knew that. That's good. So the most common cause of, so you probably saw it on my other slide.
Yeah, exactly.
Oh, that's good. So the most common cause of end-stage kidney disease in New Zealand, but also worldwide, is diabetes, diabetic nephropathy. Number two is generally glomerulonephritis. Number three, hypertensive nephrosclerosis. Number four, polycystic kidney disease. And then you get things like drugs, congenital abnormalities, autoimmune disease, lots of other causes. So in the early stages of chronic kidney disease, often we'll start to get hypertension and proteinuria and we'll target that. But then in stage 3 and stage 4 chronic kidney disease, we're starting to get other metabolic abnormalities. Stage 3 chronic kidney disease, we start to get anemia, a fall in the blood count, And also we're getting the early stages of CKD bone mineral metabolism abnormalities, so changes in the bone. So we'll start to target therapy in those areas with stage 3 and stage 4 chronic kidney disease. So you remember, as you develop progressive chronic kidney disease, you'll tend to be anemic. And we see that because there's a reduction in erythropoietin production, and also reduced red cell survival and more inflammation. And as you can see, as you develop worsening CKD, you start to get anemia being more and more common. And really, we're usually only seeing this a little bit in stage 3, more in stage 4 and stage 5 chronic kidney disease. And this anemia is multifactorial. So as I mentioned, we get a reduction in EPO production. Often patients can be iron deficient and are more prone to losing blood. There's a reduction in red blood cell survival. And some of the drugs that we use may contribute. And also there's inflammation, which tends to lead to anemia. And we really focus on correction of iron deficiency. So many patients will have increased iron losses, which can be through the gastrointestinal tract. And iron tends to be less effective due to chronic low-grade inflammation. So we'll often check for iron deficiency anemia, and you remember that often ferritin is a great marker, and if it's low, it represents iron loss. But ferritin will also go up in cases of inflammation. So you might have normal ferritin, but still have a relative iron deficiency. And in those situations, we're often relying on the serum iron and the percent iron saturations. And we may even look at the percentage of hyperchromic red cells or transferrin saturations, depending on your center. And if patients do have early anemia, then we'll often correct that with the use of iron. And that use of iron can be either oral or intravenous. Oral iron comes in multiple different forms. I tend to prefer ferrous fumarate, just because it's got relatively more elemental iron. So 200 milligrams of ferrous fumarate is the equivalent of 325 milligrams of ferrous sulfate. You can give it either daily or alternate daily. But it does have some side effects, which we mostly think are related to the gastrointestinal tract. So some people who take oral iron will tend to get constipated. They can often get a metal taste in their mouth. And in really severe situations, they can get quite nasty epigastric distress and or vomiting. But we do try and target increasing the serum ferritin, especially if the patient is on dialysis. And we can see that pushing the iron levels to normal or even supranormal levels can correct the anemia of chronic kidney disease that we see in stage 3, stage 4. If the patient can't tolerate oral iron, then we'll often use IV iron, which obviously is bypassing the gastrointestinal tract. And the thing with IV iron is that you can give a large dose, so it very quickly repletes the iron that's needed. And if you've got things like bleeding related to heavy menstruation or blood loss from the gastrointestinal tract, then you often need IV iron. And you remember there are multiple different preparations. Typically in dialysis units, we'll be using iron polymaltose, but iron sucrose is less immunogenic, so you're less likely to see reactions. And ferric carboxymaltose, Ferinject, can be given very rapidly without developing side effects. So anyone with iron can get an allergic reaction, but iron dextran tends to be mostly far more immunogenic than the other medications. So I think in the dialysis unit, our unit will tend to use iron polymaltose. For outpatients, because the iron can be given far more quickly, we'll tend to use Ferinject. And we can calculate the amount of iron that's needed based on a formula. So we can look at the patient's body weight, look at their hemoglobin, and work out the amount of iron that's needed if we're going to chart IV iron for them. And as mentioned, this does have some adverse drug reactions. You can get a change in your mouth. You can get headache, muscle aches and pains, shortness of breath, itch, and you can drop your blood pressure and become tachycardic. So we do tend to give this in a monitored situation.
Janak, I have a question.
Yeah.
For our patients on dialysis, when they have an active infection, we've been advised to not give their regular iron dose that we've been giving. Could you tell me what is the reason behind that?
Yeah, so iron is often a substrate for many bacteria, and it's generally thought, like if you add ferritin to cultures, you'll find that bacteria will grow more quickly. And I think a number of observational trials have suggested that if you treat patients who have active infection, you're less likely to recover or respond to therapies. But also with infection, you've got inflammation going on. And so iron finds it hard to move into a functional state. So I think generally we recommend that patients don't use IV iron when there's active infection on board.
Thank you.
So the other component in chronic kidney disease, as well as iron, a relative iron deficiency or less effective iron, is erythropoietin. And you remember that erythropoietin is secreted in both the kidney, but also a little bit in the liver. So we find that the amount of EPO that you will produce relates to your hemoglobin. And so if you're hypoxic or anemic, the natural response of the body is to produce more EPO. However, with progressive chronic kidney disease, you lose or have a reduced ability to do so, because your liver hopefully could be working reasonably well. And so what we do see is as people develop progressive chronic kidney disease and their GFR drops to less than 30, they're far more likely to become anemic. And typically we will correct this first with iron, and then secondly with the use of recombinant erythropoietin, a synthetically manufactured form of EPO. EPO does have some significant side effects. So if you give EPO, you tend to push people's blood pressure up, and you tend to be more likely for them to have a thromboembolic event, whether that's a clot, a stroke, or heart attack. There are some suggestions it's associated with increased hematological malignancies. And in some patients, they can get an allergic reaction where they get antibodies produced against hemoglobin and develop what we call pure red cell aplasia, where they've got antibodies which target the red blood cells, so the hemoglobin drops even more precipitously. So we do have to be cautious. And typically we try and treat people with EPO after correction with iron if their hemoglobin is less than 100. And typically we're treating the hemoglobin to a target of between 105 and 120 grams per liter, such that we're not pushing the hemoglobin up too much, so there's increased risk of strokes and clots without getting much benefit. And so you'll know this from your QA time. If you've got a hemoglobin of more than 100 and the patient's on iron or the patient's on EPO, we'll tend to stop the iron or reduce or halt the EPO as well. One thing to be aware of is that there have been a number of trials of oral agents, the oral hypoxia inhibiting factors, which are now coming into clinical practice. And so these drugs target inflammation and target Herceptin and aim to improve hemoglobin with an oral agent. And so in the future may replace EPO. And there have been phase 1 trials and now clinical trials in patients with chronic kidney disease and on dialysis, which show these drugs are safe and effective. but unfortunately they remain unfunded in New Zealand, so we don't have access to them. So that's one thing to look out for in the future. Ooh, question in the chat. Oh, sorry, that was from a while ago. Yeah, so CKD bone mineral metabolism, early stages start to develop in stage 3 chronic kidney disease, but really become more marked in stage 4 and stage 5 chronic kidney disease. And so we see that the kidney doesn't excrete phosphate as effectively. We see an increase in FGF23. We see a reduction in activated 1,25-hydroxyvitamin D, leading to hypercalcemia and secondary hyperparathyroidism. And so in chronic kidney disease, we'll start to see hyperphosphatemia, which can cause damage to the vasculature. And we start to see left ventricular hypertrophy, heart failure, all of which is predisposing to cardiovascular events. So how do we manage this? The first thing is lifestyle changes. We ask the patient to cut down on phosphate in the diet. Secondly, we give them tablets which bind phosphate. And these tablets are generally taken just before or with meals. And the two that we have readily available in New Zealand are calcium carbonate and aluminium hydroxide. So the idea is we give these tablets just before the meal. When they get to the stomach, the acid environment, the calcium or the aluminium component separates and then can bind to phosphate that's in the food. So often we'll take 1 to 3 tablets with meals. Calcium-based binders are really effective, but they do carry the risk of hypercalcemia. And because we're giving the patient more calcium, it does increase the risk of calcification, especially in those blood vessels. So we think it might increase to ischemic heart disease and also calciphylaxis, if you guys have seen that. Aluminium is probably more effective than calcium, but it can build up in tissues and it can cause dementia and anemia. Cevalomar and lanthanum are the newer agents. By newer, I mean they're probably 10 or 15 years old, or in fact older than that, but they're not available or funded in New Zealand. Cevalomar and lanthanum tend to have less vascular calcification and tend to be as potent, if not more potent, than the calcium-based tablets. So by potency, I mean that the relative phosphate lowering you get from one tablet is greater. So 1 tablet of cevalomar will tend to lower serum phosphate much more than 1 tablet of calcium. And so we can minimize pill burden for the patient. And magnesium-based salts have been used, but they do tend to cause hypermagnesemia, so generally not used in clinical practice. So the changes we'll start to see include high phosphate, low calcium, and secondary hyperparathyroidism. And that secondary hyperparathyroidism, where the PTH gland is more active, tends to cause increased movement of calcium from the bones. And because of that, it means that the patient has an increased risk of fractures. In addition, that calcium that's being moved from the bone tends to deposit in the blood vessels or the soft tissues. So we think that this is contributing to increased cardiovascular mortality, or if it gets into the soft tissues, can cause ectopic calcification, calcification or calciphylaxis. And we think that this is increasing morbidity and mortality. So we do try and correct hyperparathyroidism and typically aim for a PTH of between 10 and 30 picomoles per liter. And we'll correct that with either first, second, or third generation medications, calcitriol, alpha-calcidol, or paracalcitrol. And guess what? In New Zealand, we've only got easy access to calcitriol. Now, if PTH is starting to go out of control and is extremely high, so PTH is of more than 100 100 plus, and not responding to diet, calcium binders, and calcitriol, then we'll start to use the calcimimetics. And cinacalcet has just become funded in the last 6 months in New Zealand. And I'm sure you guys are starting to use that. I know that that started to come into my clinical practice. And it allows us to avoid doing a surgical parathyroidectomy. Okay, so key message number 2 is that in progressive chronic kidney disease, you're going to start to get anemia, which is multifactorial. And initially, we're going to treat relative or absolute iron deficiency first with either oral or intravenous medications. And if the patient is iron replete and the hemoglobin is less than 100, then we'll start to use EPO. And hopefully in the future, we'll be able to use oral erythropoiesis stimulating agents. In CKD bone mineral metabolism, we'll start to get hyperphosphatemia, and we'll address this with diet, phosphate binders, and monitor the PTH. And if this starts to go above target, we'll give the patient activated vitamin D. Okay, so any questions? Oh, okay. So then as we get progressive chronic kidney disease, we'll start to get CKD4, we'll start to get a few other problems. And one of those key problems is metabolic acidosis. Because you remember that the kidneys will excrete acid and also important in regeneration of bicarbonate. So as we develop metabolic acidosis, this can accelerate the progression of chronic kidney disease. That acidosis will cause destruction of the bone and accelerate osteoporosis. And with these effects is associated with increased mortality. So often we'll try and treat that metabolic acidosis, and we'll try and do that with lifestyle changes or medications. So a move from animal to vegetable proteins will tend to reduce the production of the volatile acids, and so it can help correct metabolic acidosis. And then typically we will use something to correct acidosis, such as sodium bicarb. And you remember there are sodium bicarbonate tablets. And we'll typically give the patient oral bicarb, trying to target a serum bicarb concentration of 24 to 28 or 29 millimoles per liter. Bicarb does have side effects, and the major one is bloating, as well as pill burden. So in those situations, we can use urate, and often in the form of urale sachets. And urale sachets can be effective. However, it can also increase aluminium absorption into the serum and thus reduce its effectiveness as a phosphate binder. And also the sodium citrate urale, it comes in oral sachets, so it can contribute to volume overload, especially in the more advanced stages of chronic kidney disease. Hyperkalemia is very common, especially as we're getting closer to stage 4, stage 5 chronic kidney disease. And what are the risk factors? A high potassium diet, a low urine output, and specific drugs such as the ACE inhibitors, ARBs, and non-steroidals. And of course, hyperkalemia is an emergency. So when the potassium starts to go up, we can see disorders of cardiac function, prolongation of the PR interval, widening of the QRS, and peaking of the T waves, which can go on to the patient developing a cardiac arrest. So if the patient's developing hyperkalemia, then we're going to try and address that. And the first thing is change in diet. The second thing is looking at drugs. And the third thing is correcting metabolic acidosis. And if you've got severe hyperkalemia, which is life-threatening, then we're going to treat that with intravenous calcium gluconate, insulin dextrose, beta-adrenergic antagonists such as salbutamol, bicarbonate, and then things like rosonium. And if needs be, we'll use dialysis. So key tip, as is as chronic kidney disease progresses, you start to get early hyperkalemia. And the first thing we want to do is correct metabolic acidosis, not embolic acidosis, I apologize. And we'll often look to reduce the ACE inhibitors or ARBs. Another common factor with CKD5 is the development of fluid overload. And so that's contributed to a high salt diet and high fluid intake. So often what we'll do is ask the patient to salt restrict, and we'll typically use diuretics, but we need to just be aware of adverse drug reactions from these with the development of hyponatremia and or ototoxicity with very high doses of furosemide. Remember, there are different types of diuretics. Typically, we use the loop diuretics to help with volume overload, but the thiazide diuretics tend to be more effective with natriuresis. And if the patient is developing a low potassium, then we might consider using potassium-sparing diuretics rather than giving them a diuretic and potassium replacement. So keep slide number 3. As you're developing worsening chronic kidney disease, stage 4, stage 5, you'll start to get metabolic acidosis. And in those situations, we'll correct this with diet and bicarbonate. You might get hyperkalemia, in which case you'll again change your diet and maybe cut down on the ACE or the ARB. And then we'll try and treat volume overload with salt restriction and use of diuretic. So any questions around that? So of course, if you developed advanced chronic kidney disease, that can lead to kidney failure and the need for dialysis. And so common dialysis medications include intravenous iron for hemodialysis, or for patients who are on PD, we may use oral iron in those scenarios. We'll typically use EPO to try and correct hemoglobin with those two medications, aiming for a target hemoglobin of 105 to 120 grams per liter. We'll try and lower phosphate and correct secondary hyperparathyroidism such that the PTH is between 10 and 30 using phosphate binders and calcitriol. When you start dialysis though, we typically don't use as aggressive diuretics, and we typically stop correction of metabolic acidosis because dialysis will hopefully replace those functions. Okay, so any questions?
Janak, just about what you said earlier, you said we stop diuretics if a patient is started on dialysis. Would that be for patients who still, yeah?
Especially if they're anuric. So I mean, look, I take your point. Often we're using diuretics in concert with the dialysis. However, if they become anuric, or they can be controlled with just fluid restriction and the renal replacement therapy, we'll often try and cut their pill burden by cutting down on diuretics.
Would giving diuretic affect if the patient has residual renal function and we start them on dialysis, would giving diuretic affect their residual renal function in any manners?
Yeah, so there have been quite nice studies where they've used diuretics and collected 24-hour urines. And what they show is that you might affect the volume, but in terms of creatinine clearance, you're probably not affecting the removal of urea or creatinine. So there have been studies in PD patients where people have had diuretics or no diuretics, and they've collected 24-hour urine samples, sent that to the lab. And what you show is until you get a urine, if your urine output's more than 500 mils, you can probably increase the urine volume, but you're not increasing the amount of waste product removal within the urine. Does that make sense? So it depends on what you're thinking about in terms of residual renal function. And the flip side is there have been nice studies that show that, like, if you use big doses of diuretics and your urine output's less than 500 mils, that drug is probably not being filtered by the kidney and probably isn't effective. So usually we say that, look, if your urine output's less than half a litre, or obviously if you're anuric, there's no value in terms of volume with the diuretics, and certainly no benefit in terms of waste product removal.
Okay, thank you.
Okay. So question number 2. Who can tell me who that person or those people are?
Selena Gomez and her friend. I don't know the name.
That's right. And bonus points. Why is she holding a friend's hand?
Yeah, renal donor and recipient.
Yeah.
That's right. And question number 3, because you guys are awesome. What was wrong with Selena Gomez?
Lupus nephritis.
Yeah, that's right. Yeah, she had lupus, right? And so I think she got a transplant a few years ago, but she's been in the news again about the side effects of prednisone.
Yes, it's seen a bit. Is it the puffiness you're talking about?
Yeah.
Yeah.
That's right. So, of course, if you get progressive, first goal is slowing progression of chronic kidney disease. Second goal is initiation of renal replacement therapy, which can be in the form of dialysis or kidney transplantation. And we think transplants are better because they offer a better quality of life, but also a better quantity of life. And so we use different and specific medications in transplantation to prevent rejection. And we also use medications to prevent the side effects of the drugs that we give. So typically we're giving, in the old days, you remember that the first 5 or 6 people who got kidney transplants failed because of rejection. And then we used to use high dose steroids and total body irradiation, and people started to survive. And then there was the prednisone azathioprine era, where 50% of kidneys would fail at 1 year. And now we've moved to the prednisone, mycophenolate, calcineurin inhibitor era, as well as using induction antibody therapy. And with that, we see that 95% of transplants are functioning at 1 year. And our rule of thumb is that we say, look, with the deceased donor transplant, we expect that you're going to get 10, 12 years of that kidney working. And with a live donor transplant, we can get 15 plus years. So we commonly use immunosuppressants, but those drugs which are suppressing the immune system have side effects. And the typical side effects include infection, which can be bacterial or viral. And steroids can increase your risk of GI bleeding. And so we'll often use gut protection, and increase osteoporosis risk. So we want to protect the bones. So in terms of thinking about immunosuppressants, the standard of care is induction therapy with monoclonal antibodies. And in the Auckland and in New Zealand, we tend to use basiliximab. Other centers may use ATG, but we tend to save that for severe BAMF2 rejection. And we'll use maintenance therapy, typically with steroids, prednisone, a proliferative agent, typically mycophenolate, and a calcineurin inhibitor, either cyclosporin or tacrolimus. Sirolimus, I think, has probably gone out of vogue, but can be used if people are getting reactions to cyclosporin or tac. And so typically we will start with high-dose corticosteroids, and start to wean that so that at the end of 12 months, patients are on 7.5 or occasionally 5 milligrams of prednisone. Typically, we'll use mycophenolate as our anti-proliferative agent, or azathioprine as if people can't tolerate mycophenolate, typically using a dose of 1 gram twice a day, or 1 to 2 mg per kilogram per day of azathioprine. And we'll tend to use a calcineurin inhibitor and check the blood level of these drugs to try and achieve specific targets. And the target concentration is typically much higher in the first month of transplant when the body hasn't habituated compared to the 12-month level. And so these drugs do have side effects. And as I mentioned, prednisone tends to give you weight gain and can make you puffy. It can upset your stomach and is a risk factor for GI bleeding, and increases your risk of diabetes, osteoporosis, and also accelerates cataracts. Cyclosporin pushes up your blood pressure and can make you very hairy and cause thickening of the gums, gum hypertrophy. Azathioprine causes myelosuppression. Mycophenolate, typically we get GI side effects. And tacrolimus pushes up your blood pressure, is diabetogenic and gives you tremors. Sometimes, despite appropriate immunosuppression, we still see rejection. So, I mentioned to you that 95% of kidneys are working at 1 year, but about 10 to 12% of people in that first year will still have acute rejection. And if we have acute rejection, we'll diagnose that typically with biopsy, and we might treat with methylprednisolone, tweak of the drug levels, so try and aim for the calcineurin inhibitor to be a higher concentration. And with significant vascular rejection, we might treat with an additional immunosuppressant such as thymoglobulin. So my key message to you, number 4, is that for transplantation, we'll use an induction agent, typically basiliximab, maintenance therapy with prednisone, mycophenolate, and a calcineurin inhibitor. And if there's vascular rejection, we'll treat with methylprednisolone plus or minus thymoglobulin. The calcineurin inhibitors, cyclosporin and TAC, will tend to monitor levels, whereas prednisone and mycophenolate, we just tend to treat based on protocol. And there are significant adverse drug reactions, most commonly infection in the first 12 months. Because you remember that the immune system plays a key role in terms of preventing infections, but down the track, one of the risk factors we see are malignancy. And so at 12 months, we move more towards a malignancy prevention screening role in patients with transplants. Okay, so any questions for me around transplant medications? So when we think of chronic kidney disease, in the early stage of CKD, the drugs that we're super keen on are the ACE inhibitors or ARBs, and other drugs to control blood pressure, including diuretics, calcium channel blockers, beta blockers. In stage 3-4 chronic kidney disease, we're focusing on agents to correct anemia, iron, which can be oral or IV, and erythropoietin, and agents for CKD bone mineral metabolism, phosphate binders, vitamin D. In stage 5 chronic kidney disease, we're also worried about metabolic acidosis, and we might use sodium bicarbonate, and we're keen on diuretics to help with volume overload. If patients develop hyperkalemia, we want to use diuretics, insulin, salbutamol, rosonium, and oral bicarbonate. And in terms of transplant medications, we're keen on basiliximab, thymoglobulin, prednisone, mycophenolate, TAC, cyclosporin, and IV methylprednisolone and thymoglobulin in cases of rejection. Okay, so I've done a quick run through of commonly used drugs that we'll use in chronic kidney disease. Touched on dialysis because I think you guys probably know all about dialysis medications, and then tried to go into a little bit more detail about transplantation. Any questions for me on that? Okay, so look, I hope you're all well. We've been having exciting times the last few months. I know Hawke's Bay, Gisborne, East Coast have been absolutely hammered. So, we're all thinking about you guys and wish you well and hope to see you at some meetings.
Thank you, Janak. Thank you, Janak. Thank you so
Thanks.
much.
No problem.